In this presentation, we will explore the essential principles of insulin therapy. This includes understanding when to initiate insulin, setting appropriate therapeutic goals, selecting the appropriate insulin types, managing dosages and titration, and addressing potential complications. By the end of this session, you will have a comprehensive understanding of the role insulin plays in the management of diabetes. Insulin therapy is indicated in two primary scenarios: type 1 diabetes mellitus, T1DM. In individuals with type 1 diabetes, insulin therapy is essential due to the inability of the pancreas to produce adequate insulin. Insulin treatment must be initiated immediately upon diagnosis to support metabolic needs and prevent acute complications such as diabetic ketoacidosis, DKA. Type 2 diabetes mellitus, T2DM. Insulin therapy is considered in type 2 diabetes under specific conditions, such as persistent hyperglycemia despite maximum tolerated doses of oral antidiabetic medications. Acute or severe hyperglycemia, typically characterized by blood glucose levels exceeding 300-350 mg per deciliter, or HbA1c greater than 10%. Acute medical conditions, including infections, myocardial infarction, or surgical stress, where oral antidiabetic agents may be insufficient or contraindicated. Pregnancy, when glycemic targets cannot be achieved with non-insulin therapies, as insulin remains the safest option for both mother and fetus. Certain situations demand specific considerations when initiating insulin. Severe hyperglycemia, defined by random glucose levels exceeding 300-350 mg per deciliter or HbA1c above 10%. Symptoms often include polyuria, polydipsia, fatigue, and blurred vision. Insulin is preferred because oral medications act slowly and cannot reduce glucose levels quickly enough to prevent acute complications. Acute illness, conditions such as infections, myocardial infarction, or stroke can impair glucose control due to increased stress hormones like cortisol and adrenaline. Insulin helps address glucose fluctuations rapidly, minimizing the risk of complications. Pregnancy, insulin is the preferred therapy as it does not cross the placenta and provides better glycemic control. Oral agents like metformin or glycemic may be considered only when insulin is not feasible. The objectives of insulin therapy can be categorized into two main areas: glycemic targets, fasting blood glucose levels 80 to 130 mg per kilotons, postprandial glucose levels less than 180 mg per kilotons, HbA1c generally less than 7%, though individualized targets may apply for older adults or patients with significant comorbidities. Long-term goals: reducing the risk of microvascular complications, including retinopathy, nephropathy, and neuropathy. Preventing acute complications such as diabetic ketoacidosis, DKA, or hyperosmolar hyperglycemic state, HHS. Insulin formulations vary by their onset of action, peak effect, and duration. Key categories include rapid-acting insulin, examples Aspart, Novolog, Lispro, Humalog, Glulisine, Apidra. Onset 10 to 30 minutes, peak 1-2 hours, duration 3-5 hours. Primarily used to manage postprandial glucose elevations. Short-acting insulin, for example regular insulin, Humulin R, Novolin R. Onset 30 to 60 minutes, peak 2 to 4 hours, duration 5 to 8 hours. Traditionally used for preprandial glucose management but now less common due to convenience issues. Intermediate-acting insulin, for example NPH like Humulin N or Novolin N. Onset 1 to 2 hours, peak 4 to 12 hours, duration 12 to 18 hours. Typically used for basal insulin coverage. Long-acting insulin, for examples Glargine, Lantus, Datamir, Levemir. Onset 1 to 4 hours, peak minimal, duration 24 hours, used for consistent basal insulin needs. Ultra-long-acting insulin, Digludec, Tresiba. Onset 1 hour, duration 42 hours, preferred for patients requiring less rigid dosing schedules. Selecting the right insulin regimen depends on the patient's condition and glucose control needs. Basal-only regimen is appropriate for patients with fasting hyperglycemia or those requiring minimal insulin support initially. Basal bolus regimen combines basal insulin for background control with prandial insulin to manage mealtime glucose spikes. premixed insulin like 70-30 or 75-25 mixes, typically given twice daily before breakfast and dinner for patients with consistent meal patterns. Special conditions like MODY, maturity-onset diabetes of the young, is initially managed with sulfonylureas, but insulin is required as beta cell function declines. Early insulin therapy is recommended to preserve beta cell function in LADA, latent autoimmune diabetes in adults. Initiating insulin therapy in type 2 diabetes typically begins with basal insulin. Starting dose is 10 units daily or 0.1 to 0.2 units per kg per day of a long-acting insulin, such as glargine or ditimer. Should be increased by 2 to 4 units every 3 to 5 days to achieve fasting blood glucose levels of 80 to 130 milligrams per deciliter. In basal bolus regimen, prandial insulin, e.g. rapid-acting insulin, is added before meals if fasting glucose remains uncontrolled or postprandial glucose spikes persist. Initial dose is 4 units or 10% of the basal insulin dose. While insulin therapy is highly effective, it is not without potential challenges. One of common complications is hypoglycemia. Symptoms include sweating, tremors, palpitations, confusion, and in severe cases, seizures. Prevention involves patient education on recognizing symptoms, timely consumption of quick-acting glucose sources, and careful dose adjustments. Weight gain is one of other complications as insulin promotes fat storage, necessitating the reinforcement of dietary counseling and regular physical activity. Repeated injections at the same site can cause lipodystrophy, emphasizing the need for proper site rotation. Insulin resistance. Escalating doses may be required, particularly in overweight or obese patients. This concludes the discussion on the essential principles of insulin therapy. Thank you for your attention.